Okay, everybody, here we go with our last lecture of this term, chapter 12, and then we're going to launch into next term, which was going to be a lot of more of the organ systems in actual cases. So I'm going to go ahead and share my screen with you so that we can get started into this. All right, let's jump into the PowerPoint. So this term, this chapter, we're going to be talking about surgical case management. So a lot of it is about what is your role in the surgical case and how it's managed. So in this chapter, you are going to learn the things that help you analyze the role of your job in caring for the patient, how to verify pre-op routines, how to demonstrate transportation of the patient and apply the principles of positioning, demonstrate techniques of opening and prepping supplies and instruments that are needed for the procedure, all the time while maintaining that sterile technique. Summarize the methods of preparation of the operative site for surgery, demonstrate the application of thermal regulatory devices, so BOVIs, interpreting the principle and demonstrate the taking of and recording of vital signs. I know this is something that you've not done yet. In many places you won't need to, but it's good to know just for completion's sake. Interpret the principles of urinary catheterization and demonstrate the procedure. And you will definitely work with that procedure next term. I know that Tawny and Yolanda, you've already been taught that in my teaching. So we will have them do that next term for sure. Analyze how the principles of the operative site prep and urinary catheterization are related, both to the patient care and to the principles of asepsis. Demonstrate the proper techniques for the surgical hand scrub, gowning, gloving, and assisting the team members. And then demonstrate the proper technique for preparing supplies and instruments on a sterile field, and demonstrate and explain in detail the procedure for counting instruments, sponges, needles, and other items on the field. And then demonstrate the initial steps for starting a procedure, as well as handling sterile equipment and supplies during the procedure, and summarize and demonstrate post-op routines. Okay, so as a surgical technologist, the main thing that you will be doing during the perioperative case phase is basically just providing the case management. And so that is helping everything basically move along smoothly and maintaining your process as far as preparing for the case. So during the three phases that we have, the pre-op, the intra-op, and a post-op. We talked about this in previous chapters, so this is not new to you, but just know that we're going to talk about each phase as far as what is going on and what is your role. Now, anticipation, we know that this is the number one thing that makes you a really good tech is, of course, once you've got sterile technique down pat and maintaining that of course is the ultimate number one. But then aside from that, the anticipation, that's the ability to anticipate or predict what the surgeon is going to need during that case management. And that, of course, is one of the most important skills of a surg tech. And it can be basic, which is where you are in the beginning of your career, but it can also get refined, which makes you an even more valuable asset to the team. So just know that as you move into that clinical setting and you start to gain that experience, then your level of anticipation will start to increase. Preoperative case management, of course, this is going to begin at the very beginning of the day. And then it may be repeated several times. And so this is really kind of giving you a preview of what's going to happen in the case and what's to be expected and what the outcome goals are, any complications that the surgeon may anticipate running into. It's kind of just a a way to prepare everybody for the case so that it's managed appropriately. So because once you're prepared for what could go wrong in the case and what is expected to go well in the case, then the case usually proceeds a lot easier. And of course, then the situation is going to be described as ideal, so how we would want the case to go. But of course, complications will be discussed based on each individual case. The patient routines, of course, there is a psychological and physiological preparation that is done. They want to make sure that they're prepping the patient for the risk of the procedure, what the goal outcome is, and then physiologically, any cleansing that needs to be done. And this is pretty common in major type surgeries that they may have to shower with chlorhexidine for several days because it takes longer to start taking the effect, but it does last longer. So, there's a lot of prep that's done. And if it's a GI case, then there's going to be some GI cleansing to be done just to clean the area so that there is less possibility of contamination. And then, of course, lab work. Lab work has to be done prior to cases so that the most recent values are known, so we know exactly where the patient is, that status is at, and also surgical preparation. So not only the skin site and the internal cleansing, but just making sure that all of the things are in place in the event that anything does go in the direction of less than ideal. And an example of that would be having the blood type performed already and crossed, and so that in the event that there's blood needed, that's known what type and have it available. And then, of course, making the patient physically and mentally comfortable. Physically, this is about making sure that if there's any skin that needs shaven or and then the prep, of course, is going to be done pre-op as well. But then mentally comfortable, really helping the patient feel at ease as much as possible is going to improve the outcome of the case. Patient chart information, the circulator is going to make sure that's all up to date. And the items that are going to be found in that chart, labs, of course, radiology reports, the consent forms signed, preoperative list, special consent forms, the pathology reports that may have come in before that, nurses' notes prior to the surgery, history and physical, allergies, and handicaps. Now, the circulator's role and responsibility, this is important that you know this because in many facilities, especially smaller facilities, you may be asked to perform this role. So you have to know the roles and the responsibilities of each team member. It also helps you know who to call on in times of need, because once you know their job, you are able to ask them to support you in their role. So they do the primary patient prep. They make sure that the diet is in accordance with the procedure, and that usually would be a time frame of fasting. So it depends on the case. It's usually no less than 8 hours and preferably more closer to 10. If enemas are needed, that's performed by the circulator or the pre-op staff. And then pre-op hygiene. So there we're talking about cleansing the skin, shaving the skin, hair removal, nail polish removal, any makeup, clothing, of course. Possessions are going to be locked away in a safe place. And then pre-op education again, just informing them of what's going to be going on and the steps that are involved. And then sedation, of course, is going to be part of that as well. Usually the circulating nurse will do an IV type of sedation agent prior to the patient being rolled into the OR most of the time. They may be semi-conscious, but they won't remember it usually. And then patient transport to the OR. So this is, you do play a role in this in many facilities. And so you just want to be educated on what's going on, especially if it's like in an outpatient type surgery facility. A lot of those have smaller staff because they're doing a higher number of patients. So you want to make sure that you're prepping the case, knowing that there's other activities concerning the patient that are taking place at the same time. And so there's a lot going on for that patient and the family during that in that time. And so notifying the same day surgery department when the patient's going to be picked up. This may or may not be your role, but you definitely want to make sure of the steps in case it is your role at some facility. And then, of course, positioning the patient for the procedure, and that's going to be on your preference cards. And then performing the skin prep. That also is going to be on the preference card as far as which type of skin prep is preferred. You will learn that. If you haven't this term yet, you will learn it next term. You'll be doing skin preps and positioning as well. And then making other patient care preparations, just whatever is needed, basically. And then in the text, you know, there's some transporting techniques, and I've got a video actually I'm going to show you that's a lot better than what is in the book. So we're going to look at that transfer. Let me go ahead and get over to the book. Okay, so here, technique 12-2. This is the textbook version. So keep this in mind, because you're going to see textbook, which is what board exam is going to be testing you on. But the reality is, once you get in a facility, all facilities usually have an elevated number of team members that are performing these transfers. So it depends on the patient. You know, that's going to depend on the patient's mobility. It's going to depend on their weight and stature. You know, if they're really long or heavy or immobile and have some extenuating circumstances. So let's say you have someone with cerebral palsy that has a lot of contractures. That's going to take more team members just to ensure the safety and the comfort as well. And so the technique goes like this. You know, the mobile patient may be able to move to the operating table by themselves. And so this would require just a minimum of 2 non-sterile team members just to be available to assist the transfer, because it's also cumbersome. They're in the gown, they're having to move from one table to the next. And so the technique, you're going to position the stretcher next to the operating table as close as you possibly can, lock the stretcher so that it has no mobility, instruct the patient not to move until you command them to. And then, like I said, be sure that the wheels of the stretcher and the OR table are locked and secured. One individual is going to be positioned on each side of the stretcher, or at the side of the stretcher, and then someone on the side of the operating table. And then you brace your body against the stretcher and the OR table to prevent any unexpected movement. And then you're going to instruct the patient to keep the blanket on them, and you're going to assist them over. So you're moving pillows and blankets over as they're moving themselves. Once they're on the OR table, you're going to apply that safety strap on the OR table, and then you're going to remove the stretcher. Now, it's a little bit different, of course, if there's an immobile patient. And so that could be for a variety of reasons. They may be unconscious. They may be health-wise just unable to move themselves over for a variety of reasons. That could be the health condition that they're in the OR for, whether it be a broken bone or severe pain, or a variety of reasons. But immobile patients, they're going to be assisted in a different way. So this requires a minimum of 4 non-sterile team members. Again, positioning the stretcher next to the operating table, ensuring both of them are locked and secured. If necessary, then the transfer procedure is going to be explained to the patient. You're going to tell the patient exactly what is going to happen so that they're expecting the next move. One individual is going to be at the side of the stretcher, one at the side of the operating table. Anesthesia is going to be at the head to secure the head, and then there's going to be an individual at the feet. Now, I will say in reality, this a lot of times, depending on the patient, may require 6 people, 2 on either side of the stretcher and the OR table, anesthesia at the head, and another person at the feet. Just because of immobility, it makes it a lot more challenging. And for the safety of the staff, many times you'll have 6 in that move. It totally depends on the number of staff. Again, bracing the bodies against the operating table and the stretcher. That really helps keep everything tight in there, the OR table and the stretcher bound close together without any movement. Keeping the patient covered, transferring them over to the OR table, and then using a draw sheet or a roller board is really helpful. And I'm going to show you how that works. And then, of course, applying the safety strap before that stretcher is removed. Okay, so we're going to watch this YouTube video of patient movement.
You're probably looking at me and saying, she doesn't need that shapewear, but I definitely like shapewear because...
There we go.
At the Jewish General Hospital. You're about to watch the correct technique for patient transfer in the operating room. You might think this should be obvious, but unfortunately patients and OR personnel have been injured when this has been done without enough help.
Transferring a mobile patient to the OR bed. Note, in order to safely perform the transfer, 3 people will be required. The orderly will bring the stretcher parallel to the OR bed and lock it into place. The anesthesia team is always at the head and ensures that the OR bed is locked. The patient can then proceed to transferring from the stretcher to the OR bed with guidance from the team. The safety belt is applied once the transfer is completed. Transferring an immobile patient to the OR bed or stretcher. Note, in order to safely perform the transfer, 4 people will be required. The orderly will bring the stretcher parallel to the OR bed and lock it into place. The anesthesia team is always at the head and ensures that the OR bed is locked. A second orderly will be present on the opposite side of the patient and another.
So this is a roller board, and you'll see how it works. You do want to make sure that you are covering it with the sheet when you're using that. It just helps overall with ease of movement as well as ease of cleaning.
Member of the team, for example, a nurse, resident, or medical student, will be at the foot. The patient is turned, a roller is then placed beneath the patient, and only on the count of the anesthesia team will we proceed to transferring the patient to the bed. The patient is once again turned, and the roller is removed. The safety belt is applied once the transfer is completed. Note, the same steps will be applied in the post-surgery transfer.
So I want you to notice just a little bit about how once they got it up against the OR table, they lowered it slightly. That just allows for much easier movement of a sedated patient. See, they lowered it slightly. And they're just inserting this mover board up under that same sheet that they covered it with in the beginning. So questions, how many people are needed for the procedure? So it depends on the patient, if they're mobile or immobile. And then how is the patient's bed positioned and secured? What are the steps to transfer a mobile and immobile? What are the steps to return them? So just be familiar with all of those. Okay, and positioning, of course, there is every effort made to make the patient as comfortable as possible on the operating table. There are a lot of videos on positioning, and we're going to look at different positions in some of those as well. But first we're going to talk about thermoregulatory devices. So these are devices that are primarily used to prevent hypothermia, because we know that there's a lot of intraoperative heat loss. And so there has been mechanisms that have been developed and that really help to decrease that. And you can see here, of course, be familiar with the different types of mechanisms of loss. So radiation, convection, conduction, evaporation. So, you know, that is just our ability to lose our heat either through the air, through contact with the surface that we're on, and sweating, evaporation. So different ways that we can lose our heat in that method. And then of course, there's a lot of ways to control that, you know, so that as you can see here, there are thermal caps, there are air temperature blankets. So there's heating blankets, and you can see at this very bottom picture, this is the device that is pumping the heated air that you see in this top image, where heated air is blowing into this air blanket that's covering the patient. Very effective at keeping that heat loss to a minimum, and makes the patient more comfortable, as well as also helps with the healing process as well. Okay, so now we're going to talk about positioning, and of course this usually happens after the anesthesia has administered some sedation, and it allows for ease of that positioning as well as pain, less pain. Okay, and refer to your book as well through some of this, but we're going to look at different positions. Supine, Trendelenburg, reverse Trendelenburg, Fowler, sitting, lithotomy, prone, Kratsky, which is jackknife, lateral position, kidney, right kidney, and then Sims. And of course, in the book, let me get back over to the book, there are definitely some positions that we're going to look at. And there's, here we got supine. Of course, supine is going to be on your back, and think of supine on the spine. Arms are at the side, legs are straight. And then, I want you definitely to read through all of this, because this helps to negate some of the dangers that, you know, can happen to a patient. So this is a very safe position, and there's a lot of cases that the patient will be in supine. Trendelenburg, this is a position where the head is 45 degrees lowered. This is one method of it where the feet remain. Most of the time you see it where the table does not have the bend at the knee, where the entire table just drops into 45 degree, and that is Trendelenburg. You may wonder, why is the patient in Trendelenburg? Well, that, you know, think about a patient that's going to have an abdominal surgery. It basically, this position repositions all of the organs in a cephalad motion, so that all the organs move toward the head, and it kind of frees up a lot of visual space. And so, as you can see, there's a lot of things you can read through on this about patient safety, cardiovascular and respiratory compromise. If that is the case, then you may find that the angle needs to be decreased some. They may not can tolerate that 45, just depending on their hemodynamics. And then of course, pressure injury to skin, blood vessels, and nerve, and that would be avoided by padding the areas. Patient movement toward the head of the table, so they could slide down towards the head, and this is avoided by using padded shoulder braces. Venous stasis, so we don't want the venous system to not function and return the blood, so the anti-embolic devices, so those compression not only compression stockings, but compression devices will be applied. And then blood pressure changes can happen. And so that will be corrected by leveling the table slowly. Okay, and reverse trend, and we're going to watch videos on all this, so it'll help make it a little bit more sense. Reverse Trendelenburg, of course, is the opposite of Trendelenburg, where the feet are lowered at a 45-degree and the head is up. So this is also used when we're looking at displacing abdominal organs, caudad, and that's going to give more visualization as well. So now one downside to this is that they're going to slide off the end of the table, right? So even though that they have the strap, that's not going to keep them from sliding. So there is a padded foot rest that's applied before the table is moved into a Trendelenburg. And so that helps the patient come to that stop, just like the padded shoulder pads do in Trendelenburg. Now also another benefit that's added is when the patient is in reverse Trendelenburg, the upper body has reduced blood flow. So that helps to decrease the blood loss. Okay, and here you can see some patient safety in the reverse. If you know that padded footboard is going to keep them from moving to the head of the foot of the table. The anti-embolic devices again are used for venostasis, and the same, leveling the table slowly if blood pressure changes start to occur. And then we have Fowler's position. Fowler's is basically sitting in a particular angle. So here we have Fowler's. Of course, you can imagine this is going to be for things like shoulder surgeries. You may see this in placement of a pacemaker, things of that nature. And here we're looking at what some changes could happen and how we would correct those blood pressure changes. So there is postural hypotension, so low blood pressure depending on the posture. And so that's a very special concern that it may have to have a pneumatic compression device used for that. But other than that, they're just going to make adjustments to the table really slowly. Respiratory compromise, if the arms are not placed on the arm board in front of them, then they can be placed in front of them on a pillow and not on the chest, just because that can cause some added compression to the lung field. Of course, venostasis is always going to be corrected with the anti-embolic devices, or avoided, I should say. And then patient movement, here we have a padded footrest. Upper body is going to be restrained. Neurosurgical headrest may be used. That's the case too. So this is often used in neurosurgery. Pressure injuries to the blood vessels and nerves, then we're going to pad those pressure points. And then we have sitting position. This is definitely used more for neurological cases. And so you can see that the head is going to be stabilized with this, with the device. Everything is going to be supported at the chest and the leg region with arms across on a pillow, padded footrest as well. Now, lithotomy, we're familiar with this, of course, in LND, but any other cases as well as in males, you know, there may be prostate, any anus or rectum procedures. A patient is going to primarily be in this. There's one more that does access the anus a little bit differently, but lithotomy is usually the position of choice. Now, in this one, of course, we could have crushing or shearing injury to the hand, just because of, you can see the crushing depending on weight of the legs, things of that nature. And so to prevent that, you're going to place them on the arm boards, if not across the body. Pressure injury to the skin, blood vessels, and nerves. So with this, we're going to make sure we're padding the feet and ankles, and making sure that those restraining devices are not very restrictive. Going to make sure that the legs do not come in direct contact with the stirrups. And we're going to avoid torsion or flexion or extension of any part in excess. And lowering and raising the legs simultaneously is done slowly and by 2 individuals. So we want to make sure that you're never doing that alone. Back, knee, and hip pain, of course, these can occur. Blood pressure changes, venous changes, stasis, cardiovascular and respiratory compromises. So you can just read through all of this, see how you're going to correct those cases or prevent those situations. Prone is going to be face down. This is going to be done for any spinal surgery, posterior lower extremity, posterior cranium, or just dorsal body surface. So this is just face down. You may see it where they have almost like a massage table opening, or the head to one side or the other. And then I'll let you read through this, but on this one, you're definitely going to be using like chest rolls, axillary rolls. And with females, you have to move the breast bilaterally. And depending on the breast size, there may need to be extra cushions provided to avoid that excess pressure on the other areas. Okay, and then we're going to look at the Kraske or jackknife. This is going to be when we're needing to access either the anus or the pilonidal area. So if we're talking about a pilonidal cyst, that is challenging to reach when they're just prone. So blood pressure changes is usually the only potential hazard, and so you're just going to return them slowly to the normal position. And then lateral, of course, is going to be lying on the side. And this, we're going to see this done for any case where they're having to work. It could be ribs. I've also seen this used for specific GI procedures. And so you just want to make sure that you're taking a lot of precautions, because you can see here there's a lot of cushioning that is provided in this position. And then the kidney position, of course, this is going to be used in kidney cases for that retroperitoneal space. Potential, you can see there's going to be a lot of potential hazards that's going to have to be avoided. So there's a lot of extra positioning done in these kidney cases. Compression in many areas, so it's going to be a lot of extra cushioning, as well as reducing the table's flexion if needed. So Sims position is a modification of that left lateral. So if they're performing a endoscopy on the anus, this is the preferred position. Let's see if it had a picture. I was not thinking it did. So Sims position, and there's not really any good pictures on it, but basically what Sims position is the way that most people or side sleepers sleep. So it's, if you think about left lateral position, it is basically this position, but with the top leg moved forward. So hip flexion and knee flexion. So it's basically, like I said, how many people sleep. So it just gives more access to that, the anal opening, as well as the position of the anal canal. And it really does facilitate endoscopic entry. Okay. So we're going to watch a YouTube video. So of course, this is our Surg Tech guy that we see in the field. And so he's not an instructor, so he talks to you from a Surg Tech point of view. So just keep that in mind as you watch this.
Hey everybody, welcome back to another Surgical Tech Tips. We are back in the OR finally, and I wanted to do a video on this bad boy right here, our OR table. I haven't really gotten to talk about the OR table, and I thought it would be good to go through some positioning and kind of take you through, the controller that the anesthesiologist uses as we position a patient, and all the kind of different options and safety aspects that you can see with this OR table. Here we go. All right, so to start things off, we're going to be going over different positions on this table. And first and foremost, most common position you're going to see in the operating room as far as surgical procedures go is supine. The supine position is the body's most common way to lie. You're just lying on your back. Man, this is actually kind of comfortable. I've never actually sat on the OR table before. This is actually pretty comfortable. Arms can be out or arms can be tucked. If your arms are out, they say that you should not keep the arms out more than a 90-degree angle. So instead of a 90-degree angle, you want it just a little bit lower. If you go a little bit higher and you have an hour, 2-hour case, after that patient leaves the OR, they could have a brachial plexus injury from overextension of the arms up. So they say you should keep it at below a 90-degree angle in this supine position if you are keeping the arms out. Working on the lower half of the body. If you're working in the upper half of the body, in the abdomen or in the chest, majority of the time we will tuck the arms. We have a sheet usually over this bed. Just for this exercise, I just wanted you to be able to see the pads. But we have a sheet under this bed and there's a sheet under the patient, and we can actually tuck the arms next to the patient during a surgical procedure. We pad them, pad the ulnar nerve over the elbow, and basically pad this whole arm as we tuck it to their sides. So as far as types of procedures that you might see supine, I said before it's going to be the most common position you'll see in the OR. Pretty much anything abdominal wise is going to be supine. Anything femoral, anything in the legs, so that could be fractures, it could be vascular cases in the leg, open hearts going through the sternum, chest, that's supine. There's a lot of cases that are supine. Some of the ortho cases and spine cases can be supine as well, but we have different beds, fracture tables and Mayfield tables and stuff like that they might utilize for those types of procedures. They just have different attachments, things like that. We can go over that in another video. But majority of those cases are all going to be lying flat on the back, supine. So one of the first modifications of the supine position is Trendelenburg. Sometimes doctors like to call it head downenberg because you are placing the patient's head down. You'll see this a lot of the times in pelvic surgery when they really need to displace all the organs in the abdomen and kind of displace them up toward the head. So gravity works for us here. We're basically pulling the head of the patient down, putting the feet up, and it's displacing all those organs, cephalad, up toward the head, and that's going to give us more room to work in the pelvis. And fun fact, actually, if you are in a case and your patient is getting really Brady and their heart pressure is going down, one of the first and most effective things that you can do to bring that pressure back up is Trendelenburg. Because what you're doing is you're taking all that blood and venous drainage and sending it right toward the heart to bring the pressure of the heart back up. Fun fact. Now the opposite of Trendelenburg is, somebody guess it, you guessed it, reverse Trendelenburg. So that's going to be head uppenberg, sometimes they like to call it. And in this type of case, obviously you're displacing the organs. Caudad, you're bringing them down toward the feet. If you're working somewhere in the upper abdomen, maybe liver, maybe you're doing a gallbladder or something like that, you want a little reverse T, you'll bring the head up a little bit and kind of displace those lower abdominal organs down toward the feet to give yourself a little bit more room to work. And Just like the fun fact with Trendelenburg, with bringing the pressure up, sometimes you have to watch the pressure. If you give a little bit too much reverse T, you're taking away too much blood from the heart, and you can get a little Brady. This next position is Fowler's position. Sometimes they call it like a beach chair position. A lot of the cases that you'll see in this type of position are going to be possibly some breast surgery, breast aug, or any type of breast surgery where you need to see like the natural lie of what the breast looks like. You might see it in like shoulder scopes, arthroscopies, things like that, and even possibly any certain types of head cases as well. Now you're probably wondering why there is a big hole down here between the pads on this bed. And this hole is here and in place basically for this next position, lithotomy. We have two different types of leg devices to hold the legs up for the lithotomy position. I'm going to show you the first one. This is the candy cane. But first and foremost, after we get the patient on the bed, we put them to sleep. We will put their legs up both at the same time up in these either stirrups or candy canes, and then we will remove this portion of the bed. These little nubbins can go down by just hitting the leg down button. And now the doctor has perfect access to the patient's pelvis. A lot of the times I know you ladies know this position well because when you go to get your pap smears and stuff like that, you have to kind of be in this lithotomy position at your doctor's office. But for the men out there that do not know, oh, I can't believe I'm doing this. Let me take this off. You're basically up, open, you have access to the anus, to the pelvis. Obviously for men and women, we have different parts, but the doctors will have access to both. So OBGYNs, you'll see a lot of those types of procedures, any type of DNCs for general surgery. We can do like anal fistulas, stuff like that through this lithotomy position. Urology, cystoscopies, you'll see a lot of cystos all in lithotomy position. But yeah, that's about it. Oh, hold on, let me show you the different device here. This is the Allen stirrup for the lithotomy position. The other one was the candy cane. It's basically doctor preference at this point between the two of them. Bigger cases and cases where you need to maneuver the leg a little bit more. This Allen stirrup works great because of that reason. The candy cane, you pretty much put the legs up and that's where they're gonna stay for the remainder of the case. But these Allen stirrups, they have a lot of padding in them. I think they're a little bit more comfortable, and there's a lot more mobility that goes along with these. This next position is prone position. Prone is basically stomach down. I don't know if a lot of you sleep on your stomach. I'm a stomach sleeper, stomach inside. So I'm comfortable sleeping on my stomach, but a lot of people aren't. And this position is obviously utilized so we can work on the back of the patient. So it could be types of, I want to say spine procedures, but I know majority of the time spine procedures are done on a Mayfield bed. I'll show you a picture of that bed here. But it could be, for general, maybe some pilonidal cysts down near the anus. Could be some head and neck things, on the back of the head or on the back of the neck. Again, like maybe some lipomas back there or anything like that. So prone position, there you go. And similar to supine position, you can have, you know, the arms tucked in close to the patient, or in this case, have the arm boards up in a comfortable position and just keep the arms attached to the arm board as they're up. Now this position here is, they call this like the Kransky position or like the jackknife. Again, this is a modification of the prone position, and again, you know, could be used for like the pilonidal cysts. A lot of the times they'll do a slight jackknife. It might not be anywhere as severe as this. All right, for the last position I want to talk to you guys about, it's going to be the lateral position. Lateral position is used anytime you're going to access the thoracic space. Any type of lung surgery that you're going to do, you're going to be using lateral position. There's a couple different types of positioning devices. Sometimes doctors like to use a beanbag, which is an interesting device. Majority of the doctors I work with don't utilize a beanbag though. They'll just tape a patient. Tape a patient to the bed, but essentially the lateral position is exactly what it sounds like. Patient is lateral. Their lower leg is bent. Usually have a couple pillows in between the legs, and the top leg is straight. Your arms are out. Your arms will be out on one side, and you'll have a couple more pillows right here, just to try and keep a nice, comfortable space. That is pretty much it for the different types of positions on this table. Here's a little video of, you know, some patient padding devices that we utilize. I kind of touched on them when I was talking about the positions, but mainly we're trying to pad bony prominences that might be injured, as well as nerves that might be injured, like the ulnar nerve around the elbow. So we just have to ensure that we pad, you know, all those types of places. And, you know, the padding on these OR tables is super thick, super squishy. It's like this thick gel memory foam. It's like 5 or 6 inches thick. It's actually very comfortable. That was my first time ever even getting on this table, and it's actually very, very comfortable. Yeah, but we try and pad all those types of bony prominences and nerves to, you know, keep anything from getting damaged that, you know, we don't want damaged, obviously. Thank you guys for watching this video. I hope you thought it was a little educational.
Okay, I hope that helped make some of these positions make a little bit more sense, and especially coming from a surg tech point of view. Okay, now we're going to look at urethral catheterization. So this is something that you are typically not going to be responsible for, but you definitely want to make sure that you understand how. Of course, there is a technique in your book for you to review, because you're going to do open gloving, and then you're going to introduce this flexible tube through the urethra into the bladder, and it's going to help for drainage and or irrigation. So sometimes these are going to be done just for irrigating of the bladder. And it could also be used for decompression of the bladder, urine monitoring, drainage of the urine, like I said, irrigation, and then control bleeding. So you'll definitely take a look at those techniques and figures in the book, but let's watch this video too. Now this is a nurse, of course, and she's going to walk through the steps of what you need equipment-wise, but when we're not going to watch this entire video, but you're going to have all your supplies ready. Of course, you're going to prep the patient for this by cleaning the area and then do the insertion. Okay.
but you should be okay. Okay, 2. And then I have my third one.
So she has the swabs that come in the kit.
Okay. And what I'm going to be doing is I'm going to be cleaning from clitoris to anus, from top to bottom, 3 times. So I have 1, then I have 2, and then I have 3. Okay, so pericare is done. Taking my garbage and my gloves, and I'm going to throw them away, and I have to do hand hygiene right away after that. And our next step is getting everything ready for our sterile gloves and positioning the patient. Now, when you position the patient, you want to be positioning her in a lithotomy position, so knees up and legs separated. You do that so then you can have a really good sterile field. Okay, I'm just going to be helping you move your legs a little bit. How are you doing? You're okay? Yeah. Okay. So I'm going to place my kit right there. Right there. Okay, and I have my gloves. I'm going to do that right there. So now when you open this up, you want to reserve the bag for a garbage bag. And there's a certain way that you can do that. You don't want to kind of rip it too much, and you kind of want to shake that out so you can keep the inside of the bag sterile. So you see I'm going to do this so the inside remains as sterile as you can have it.
In the OR, you don't have to worry
In case you want
about
to use
this.
this as your garbage bag. And I'm going to put that right over here. Going to get rid of this. Now you can have a couple different types of kits. Some will have the sterile glove not to touch the inside. Okay, Mrs. Brown, how's it going?
Okay.
Good. Okay, now once my sterile gloves are on, I will not be having my hands go below my waist or anything such as that, okay? Okay, I'm removing this, and I have my first drape here. You're gonna see a shiny side and a not shiny side. You want to have the shiny side down. This does not absorb water, so if the patient were to urinate or if you were to spill water from the syringe, then it would just kind of bead up. But what you need is wrap your hands around the drape, such as that, okay? And then you're gonna ask the patient just to kind of scoot up a little bit, and you want to place that underneath the patient. And then this is the fenestrated drape. We will be using the fenestrated drape. This provides more privacy for the patient, and it also expands your sterile field. Okay. Now I have the iodine swabs that I'm not going to be using. Then I also have lubrication, which I'm not going to be using. Okay. I have my 10 cc's of sterile water, and what you're going to need to do is pop that back in order to kind of break that seal there. Okay. So what you're going to do first, this is a sterile specimen collection. I'm not going to be using that. But what you want to be doing next is you want to attach the water syringe to the balloon port. Now you do not inflate the water into the balloon port. That can stretch out that catheter tip. So you just want to make sure that that is attached really well. Good. So next step is I'm going to ask my assistant to drop in the alcohol swabs Thank you, and the lubrication. I'm going to open up these alcohol swabs, and I have 3 of them. I'm going to place them right in here. And then I have my lubrication spray. Okay. And now I'm going to take this plastic protective wrapper off the tip of the catheter. So you want to have good control as you're doing that. There's also a perforation on the side of this bag that you can rip that perforation, or you can control it this way too. Either way works. And I'm going to have my catheter sit inside that lubrication. Okay, and at this point I take a look at my equipment, and I have my swab sticks, I have my water farthest to you, and you really want to exaggerate, over-exaggerate the removal of that, because you do not want that swab, that dirty swab, over your sterile field. Okay, so I'm over-exaggerating that. So I did the side farthest away, then I did the side closest to me, and now I'm going to go down the middle. And once again, you're going from top to bottom, and I'm over-exaggerating that. Okay, Mrs. Brown, we're ready for insertion. And something else, you want to have about 2 to 3 inches away from the tip of the catheter. If it's too close, then you might break a sterile field by touching that. And then if it's too far away, you're not going to have good control over that. So I like to go about 2 to 3 inches away. Okay, Mrs. Brown, take some deep breaths for me, okay? Perfect. Good job. Now we're going to be inserting until we see urine. And once we see urine, we're going to go about 2 more inches. Okay, Mrs. Brown, I see some urine. I'm going to go 2 more inches. You did really well. At this point, I'm going to hold on to that. I'm going to anchor that catheter in place. And now I can insert my water. Very good job. And then I'm going to give a little pull just to make sure that it's sitting in the bladder okay. And it does. That feels good. So now I'm going to detach that. I'm going to remove that. And then I want to make sure that the urine fully drains into the bag, into the urine bag. So I'm going to be placing this, I'm going to be observing the urine, but I'm going to be placing this on a non-movable part of the bed. And there is a hook right here. And then I'm going to be attaching the catheter to the StatLock stabilizer right here. I'm going to make sure there's a little bit of a slack as well. Good.
Okay, now we're going to move to the male.
Here.
I want to make sure that we get the cleansing part.
This your number, and I have my 10 cc's of sterile. Okay, perpendicular to the body. And okay. Now I have my non-dominant hand, and I'm going to be placing that on the penis in the upright position, perpendicular to the body. And this is going to be the position of my non-dominant hand until the catheter is inserted. Okay, Mr. Brown, I'm just going to be cleaning. Once again, you're focusing on the urinary meatus. And you really want to have that wide area, that you don't want to be close to that sterile field at all. And then one more. Okay, Mr. Brown, I'm going to have you cough and take some deep breaths. Once again, Good. Once again, I want to be about 2 to 3 inches away. Okay, deep breath. Good. And if you feel any resistance at all, you would need to stop and let the provider know immediately. Now, with insertion for males, you're going to be going up to the point of the bifurcation. And then you're going to be anchoring that in place once again. Okay, then you can insert your water. Okay, then you give a little tug just to make sure that that is sitting well right in the bladder, and it is. Excellent, you did very, very well, Mr. Brown. Now I'm watching for the urine drain into the bag, and I'm going to be attaching that to a non-movable part of the bed.
Okay, and so that procedure is the same as with the female, and that's going to be attached to a non-movable part of the bed. So like I said, not all facilities are you going to be responsible for this ever, but there are some smaller facilities where this may be one of your responsibilities. So you want to make sure that you have an idea of what it involves, get a little practice in the OR, so that if that ever is the case, you've had at least an introduction to it. Okay, and I would recommend, you know, in that event that you know that that's going to be part of your job, just to review this and review other videos like it. So, okay, now patient skin prep. Of course, patient skin prep is going to be performed to remove those transient organisms from the patient's skin that normally lives there, and to reduce the number of the resident organisms that are on the skin. So we have resident organisms, so those things like I mentioned that are always there, like staph and different organisms, but then we have transient organisms, things that we pick up from our environment. And so we want to make sure that we're removing those and then reducing the number of resident organisms. Different types of skin preps, alcohols, iodophores, chlorhexidines. Let's look at the book again. Let me get back over to the book. Get on the skin prep. Okay, so of course you'll read through this. There's a lot of things that you're going to be doing, you know, or looking for, and you know, making sure that there's no non-intact skin, things like that. So looking at those 3 skin preps we talked about, so alcohol, that is going to definitely give a fast reduction in significant reduction in the microbial counts. But it can be irritating. So that's one thing that always has to be considered. Now, iodophores, these are less likely to cause skin irritation, and they don't have to be removed. So those are used in a lot of cases. Chlorhexidine, now this does, like it says, does not provide a rapid reduction in the skin microbial count, but provides a longer residual effect. So it lasts like 5 to 7 hours or 5 to 6 hours. So what's usually done is the patient is required to shower in it for several days prior to the procedure. So that gives a longer reduction in those microbes. So they may have to shower in it twice the day before or 3 times the day before, and then the morning of as well. So it we are not relying on that rapid reduction, that it is continuing to remove those microbes over the few days prior to the procedure. So this is something that you'll definitely see occurring. Single-use applicators, these are very common that are used for skin prep. We have those in the labs. You will be using those next term. If you've not this term yet, they are self-contained. You activate them either by breaking a portion of it inside or popping the bubble to allow that solution to flow through the sponge. And so these are done in that outward circular motion and discarded after use. So we're going to look at what that motion looks like. So here this is an abdominal and thoracoabdominal prep. You're going to start at the umbilicus. And we've seen this in the videos. You'll start at the umbilicus and you're going to do that circular motion clockwise and moving outward with each motion. So you're doing that perimeter. Read through this, of course. You're going to use the paint of choice, as they say, but the iodophores are very helpful because they provide that color distinction and allow you to see where you have been. Now, of course, with chest and breast, this is going to be a little bit different because you're starting at the center of the surgical site. And so wherever that may be, if you're operating on the left breast, you're going to start at that left center breast and work your way outward, the same as you did with the other. And then you see how the arm is encircled as well. Now, eyes, ears, face, and nose, these are going to be done a little bit differently as well. These may be done with the sheeting. You know, sheeting may be used to protect the eyes. Of course, the area has to be cleaned, but it's going to be done very carefully and precisely. And so you're going to make sure that you're not entering the eyes and the nares in the mouth because it can burn those mucosal membranes. So those are done very carefully. And so most of the time now if we're doing a procedure on these areas, of course, there's going to be a lot of caution taken as that skin is prepped. But in general cases, that area is going to be protected with the sheeting. And then with the extremities, then we're looking at starting again at the central area and using that circumferential movement to make our way out. Leg and hip procedures. Then we're going to create some boundaries. So for the foot and ankle, we're going to start at the foot and ankle or start in the center and we're going to go from ankle to knee. If we're talking about bilateral legs, we're going to do both legs from the toes to the waist. And so this is the boundaries. We're still going to start in the center, use that circumferential motion. Hip procedures, the abdomen on that affected side, the entire leg and foot, the buttocks to the table line, the groin, and the pubis area. Hand and arm procedures. In this, we're also going to have some large boundaries. So you can see here, it's going to go to the sternum, down into the abdominal border, as well as up into the neck region. So hand and arm to 7.5 centimeters above the elbow, the base of the neck, shoulder, scapula, chest to midline, circumference of the upper arm down to the elbow. And then the arm procedure would be the entire arm, shoulder, axilla, including the hand. And then the perineal and vaginal preps. These are using a downward motion. So you can see it's not going to necessarily be circular, but you're going to start on one side and it's going to be like a roller coaster motion of up and down to cover that. And then with the abdominal portion of it, then it will be a circumferential motion that's done there. Okay. We went through all of those. So now let's talk about the OR attire. Of course, you guys are very familiar with this because you're already doing this every day, which that makes you a little bit ahead. So you're going to wear these in, so when we're talking about your scrubs, your shoe covers, your hair covers, these are worn and your mask in semi-restricted and restricted areas. Let's see. I don't think I was able to use any other images. So you guys know your PPEs. you're ahead of the game using them daily. So there you are, full attire. Of course, in the operating room, you're going to apply the hair cover prior to donning your scrub suit. So that way you're not worried about hair getting on your suit. So you'll have these available more than likely in your locker room, but you can ask your techs about that. Don your scrub suit, remove any body adornments and excessive cosmetics, apply your ID badge and your radiation monitor if that's necessary. Put your OR shoes on, apply shoe covers, apply your mask and protective eyewear as needed. All right, I'm gonna let you read through this. So these are hair cover information, scrub suit, of course. Make sure you just read through this information so you're familiar with it. Mask, of course, over the bridge of your nose. With COVID, we all know how to wear a mask now. These are different kinds of shoe covers. You will see these used as well, especially if there's some large spills that are expected. And then the protective attire, of course, then we're talking about gloves as well, hand washing, protective eyewear, of course, your goggles or your shields, and then radiation protection. So if you're in ORs that are doing fluoroscopy, you'll definitely need to have your apron on. And then there's a lot of other, as you can see, there's glasses that can be used, lead impregnated gloves, things of that nature. All right. So of course, you know that you're going to do, after your surgical scrub, you're going to don your gown and gloves and double gloving. You can look at that figure in the book, but you're familiar with that. Now, preparation for the first case of the day. So of course, the first case of the day is going to be different than all the other cases, the remaining part of the day, because some activities need only be done once. So your actual surgical scrub is only going to be done in that first scrub of the day, and then you can use the gel scrub after that. And so once you are ready to go into the restricted area, you're going to do a basic hand wash. And this is before you do your initial scrub. So you are doing your basic hand wash, and then all of the equipment and the horizontal surfaces are going to be wiped down with a disinfectant solution, and then another hand wash is going to be performed. And the OR is then going to be set up. So you're going to verify that all the furniture and the equipment is present and in the right position. Any unnecessary items that are in that OR, you're going to remove those so that they're not in the way. Then you're going to arrange the furniture and the equipment for each case to allow that ease of use, efficiency, and the best possible sterile technique. And so this is going to be case dependent. And so you want to make sure that you are familiar with how that case should be prepared and which configuration that the furniture should be set up in. Okay, so here you can see, here's your back table, here's mail stand, you know, different things that you're going to place in the right position that works best for that case. Let me make sure I didn't. Okay, yes. So then you're going to gather your instruments and supplies. Of course, that you've already done on your preference from your preference card before you came to your case, more than likely, so that you've already got your kit ready and you have everything organized. So any items that are not going to be needed immediately are going to be placed on hold. I've got a YouTube video for you guys to watch how preference cards are gathered in the real setting, so that you can see like how it's done in the day-to-day world, so that you at least have a visualization of how that's going to work.
Today we're going to be talking about a tool that's going to help you bridge that knowledge gap in any and every case that you're going to see in the OR as a tech, a nurse, anybody that is in that OR, and that is the preference card. Stay tuned. Welcome back to another Surgical Tech Tips video. Today, we're talking about preference cards. Specifically, two types of preference cards that I want to talk about, and that is the preference card that your hospital gives you, and that's the preference card that you'll be pulling your case cart for. You'll get lots of info on supplies, sutures, instruments, and as well for nurses, it'll give you an idea of how to set the bed up and set the room up for specific cases. On the other side is a preference card that I think personally I make and that you should make for yourself. And those preference cards will cover anything that may go on in the case that you can't necessarily put in the hospital preference card. There's only so much room you can put on those hospital preference cards, and it's a good idea to have your own personal preference cards for specific surgeons. Maybe if you work with certain surgeons constantly and repeatedly, maybe like every Monday or every Wednesday you're working with the same surgeon, it's a good idea to make your own preference cards just for little tidbits and little things that you figure out along the way, just to make everything go smooth. And that's what we want in the OR, smooth. So let's start this off with a breakdown of the hospital preference card that is provided to you and that you use to pull your case cart. I printed off a laparoscopic appendectomy card, and this will give you an idea, a rough idea of what you may find in your hospital and what you'll be utilizing out in the field. So as we can see, the preference card starts off with the surgeon's gloves. Got to know what the surgeon wears for gloves, right? Going on down the line, we have supplies. This first grouping of supplies are actually all of our open supplies. So those are all the supplies that I'll be opening on the field for this case immediately to set up for it. Continuing down, we have hold supplies. These supplies will be on a separate part of the case cart itself. And these are supplies that may either cost a lot of money or supplies that the surgeon may not use on every single, laparoscopic appendectomy. A lot of the times at my hospital, we like to hold really expensive supplies before the patient comes in the room. We do that just in case if the case ends up canceling for some odd reason, we're not wasting, $500 for a stapler that we opened on the field. It's a good practice to follow. Continuing on, we have irrigations. Pretty simple for that. You're going to have saline on the field. Flipping the page over goes on into our instruments. Instruments that you're going to be using for the case, and sometimes in the comment section we'll have instruments that you need to keep on hold for the case. It's a laparoscopic case, so it's a good idea to always have like a major tray outside the room or a major tray on hold just in case, because you never know. Going on into the suture, again, we utilize the comment section on the suture to kind of tell whoever is setting up the case or picking the case what the suture is going to be used for. A lot of the times these hospital preference cards, the suture section can get a little bit cluttered. Every case can be a little bit different, and something different may happen. Maybe there's an umbilical hernia that they have to repair along with the laparoscopic appendectomy. So you're obviously going to need extra suture for that. Sometimes people just throw suture, in on the laparoscopic appendectomy card, and then it gets a little muddled. Continuing on, we have positioning, medications, the type of prep, dressings. Those are all things and notes for the nurses to really, really hone in on what they're going to need for the case and setting up the room on their part. A lot of the times in that comment section, we'll be able to utilize it for draping techniques too, especially in some orthopedic cases. If you have a lot of ortho doctors come into your hospital, it's a good idea to have draping techniques in those hospital preference cards as well. Even more so in your preference card, your personal preference cards. So I just want to give you a breakdown of what a personal preference card may look like. you can have a notebook and you can write little notes in your notebook and try and organize it per doctor. I enjoy doing that, and that's what I like to do. I know some people that I work with, not only do they take those notes, but they take them home, and they may have like a spreadsheet or a Google Doc or something like that, and they actually like to organize all of their doctors, all the specific surgeries under that doctor, and they have it very well organized in a fashion where they're able to just look up on their phones right into the documentation when they have a case with that specific surgeon. I think it's a great idea. Yes, it may take a little bit of work, but this is your career, this is your future, and you should put time into it. So let's break down that personal preference card, and I'll kind of give you an outline of maybe what you can adopt. So this is kind of the outline that I've come up with over time, and this is what I've used personally back when I was first learning hearts. Hearts are a different breed altogether. You really need to break down the surgery and memorize like every part of the surgery and every step of the surgery as much as you can. So I was able to utilize this tool, and Google Docs for me really helped me out in learning in hearts. So what's great about this is that I break down, my draping, specific draping, everything I need to know in the procedure for draping out a patient for this CABG, cannulation stitches if we need to go on pump. A lot of the surgeons that I work with, they all do off-pump CABGs, so majority of the time we don't have to worry about that. But I have all my cannulation stitches. I'll have list them off by where they're going to be going, the aortic, venous, retrograde, antegrade, and LV vents. And I'll also list how he or she wants the needle loaded. Forehand, backhand, forehand, backhand. A lot of these little things end up meaning a lot to a surgeon. It means that it shows how much you are paying attention to what they're doing in the process, and it makes everything about the surgery run so much smoother. Continuing on, we have mammary, distals, proximals. These are all different steps and different sections of the CABG surgery that helped me out in my learning experience. Continuing on, we have notes at the end. Notes can be anything specific to the surgery or not specific to the surgery, but specific to the surgeon in general. For instance, this surgeon, whenever they would take 2 mammaries down, it's obvious that he needed an extra chest tube. Anytime he did a CABG, it was backhand loaded all the needles for his distals and forehand for all of his proximals. And he always wants a double loaded Prolene for his repair stitches. That's across the board for the double load repair stitches is across the board for any of the vascular cases, hearts, anything that I would do with him. So use this tool as something to help you grow as a surgical tech, not only help you grow as a surgical tech, but to set you apart from everybody else in the OR. I mean, if other people that you're working with aren't doing this, this shows so much attention to detail. The surgeons are going to love you for it. They will absolutely love you for it. To finish up this video, I just want to stress the importance of keeping those hospital preference cards up to date. If you run into a case where the surgeon changes something that they want, changes a suture, changes a supply, anything that needs to be changed on that preference card, that is up to you as a surgical tech and your circulating nurse to make sure things are changed on that preference card for the next person and the next group of people that are going to be doing a case with that surgeon again. I can't tell you how much it sucks. And it happens all the time. I'm not gonna lie, it happens all the time. You get into a case, you think you have everything perfectly fine, you get to the table and the doctor's like, well, where's my suction irrigator? I'm starting to use it on every case now. What's your excuse? I'm sorry, sir, it wasn't on the preference card. Of course, that's what we all say. Keep your preference cards up to date. Keep those hospital preference cards up to date. It's a simple thing to do. Simple, simple, simple. I just want to say thank you so much for watching the video.
Okay, I hope that helped. I think it was, if nothing else, a lot of great tips on how to be the best tech you could possibly be. All right, now we're going to look at opening sterile supplies. Of course, there's techniques that you can read through and the pictures that are going to help you. Let me get over to the book. All right, so you gather your supplies. There you can see there's your preference card. You see, I love the way that he explained everything on the preference card. That was one reason that I used his video, just because of the detail that he went to for that. Here is you opening your back table pack. You guys are familiar with most of this, but I definitely want to make sure that you're reading through this. Opening the basin bin, how to do that, small wrapped package, opening peel packs. So let's watch another one of these. This is
Like a 5-0.
Pass the pants. Hand out the hats. Fork over the...
Steve, fellow co-worker and friend. And we're going to be setting up this sterile field. This is a real case. So we have our masks on, and this is full.
make sure you pay close attention to detail. I will ask a question at the end of this for part of your making sure you are paying attention to the video. So pay attention to this case. I'm going to ask you some details at the end.
Sterile technique. Here we go. So in our hospital, we have packs basically, and this is a basic pack of basic necessity items that you'll kind of need on any type of small case. Today's case, we're implanting an impeller device, and an impeller device is actually kind of an assistive device for the heart. I'll link the website to the impeller website below in the description if you guys want to check that out.
You can edit off it, can't you?
So let's do this. We opened up our basic pack long ways. It's the length of the table. Inside it has cuffs that you can put your hands underneath the cuffs, and we're both going to pull the cuffs alongside the table to open up the sterile field. Now our sterile field is open, and we're basically just going to be throwing on all the items that we'll be using for the case. Nothing. Take note that our hands, our bodies are always away from the sterile field. If you wear a badge, I always tuck my badge inside my shirt so it's not trying to hang over the sterile field or anything. Now, when you've been out in the field for a while, opening up a room and opening up a back table, you'll notice certain ways that it's easier for you to set up a case if you open it up the same way. You know, if you have a lot of small items that you're going to be using in that case, you may want to open up all those small items at the far end of the table, so when you scrub in to start setting up the case, you can start setting up your left side of the table, your working part of the table, before you start and work your way down the table as you move along. Got my gown separate from the sterile field, and I'm going to go ahead and open up my gloves. on top of that gown. And now I'm gonna go scrub in.
Just a reminder, when you're draping and gowning, when he passes me the card, I'm going to give him the end to it. He's not going to turn around. That's bad technique if he turns around. I'm going to hand it to him, so you stay facing your sterile field.
That's a pro tip. So one of the first things that I like to do when I scrub in is expand my sterile field as much as I can. So obviously I have a Mayo stand. If you have a basin set that you're gonna throw like a 3/4 sheet over or something like that, you expand it onto the basin set. But one of the first things I always do is get your Mayo stand sterile so you expand your sterile field. Hands underneath the cups of this Mayo stand cover, open it up, and just slide it on in. Throw some towels on there to make sure the instruments won't poke through the drape.
Pass the pants. Hand out the hats. Fork over the flannel.
This is a large Mayo stand, so I'm using 3 towels just to completely cover the entire Mayo. What's that? Yeah, I'll take silk ties. Maybe just like a 2.0 Lycryl and a 3.0 monocryl, like a 5.0 RB2. Steve's gonna go grab suture real quick. All right, now, for a lot of big cases, a lot of people may drape out their back table with towels. Yeah. They may drape out their back table with towels, or they may throw like a 3/4 sheet over the entire back table. This is gonna be such a small case, I really don't need to worry about any of that, so I may just put like an extra towel over where I'm gonna put my instruments. I'll check that out.
We're also doing a cardiovascular case. So whenever you're setting up a cardiovascular case, make sure you have ties, whether they're silk or Ethibond.
Now all of the movements that I'm doing on my back table right now, you should only move things one time. So when you pick something up, you should put it exactly where it needs to be. So in this basic pack, we had all of our blades were in there, a pack of Ratex, a pack of laps, we had suction tubing, a Bovie. All the essentials are in that pack for us. And notice that I'm already making my working part, my working field at the back table, and I'm setting that up first. And I'm taking every item from that basic pack and putting it where it needs to be. One movement. When taking fluids on the field, you need to verify with the person that's giving you fluids what the strength of the fluid is or what the medication is, the expiration date. You need to write all that stuff down, and you need to label it as they're giving it to you or immediately after they give it to you on the field.
Okay, so we have heparin saline. It's 2,000 units per 1,000 ml, and expiration date is June 18th.
June 18th.
And always make sure that your circulating nurse or surgical tech who's helping you does not pour your fluids over the field. Because that's bad sterile technique.
It's labeled, it's ready to go. All right, now we're going to get our instruments on the field. So I'm going to lay a towel down where my instruments are going to be, just in case any punctures may happen when I bring the instruments onto the back table. Just an extra precaution. When going in to grab the tray, make sure you come in at a right angle, grab the ends of the tray and pull straight up. If you have an extra scrub tech or circulating nurse, have them check the filters in the bottom. Make sure there's no breaks in the sterility. Good. It's good. So I can put it on my field now. Now these towels that we have are kind of weak, so I like to double up the towels to make the roll towel a little bit stronger. We're not going to be counting instruments, so this is our instrument count sheet. I'll keep it on the field though, just in case, and I'll just slide it underneath the tray. I do this on every case that we're not entering a body cavity, so we're not going to be counting instruments, but I'll still save that count sheet and just slide it underneath the tray, just in case.
You want to say anything?
No, I don't think so. So now as I go through my tray, I'm just going to be bringing out all the items that I think I'm going to be needing for this case. So that's basically it. We went through opening up the sterile field. We went through setting up our Mayo back table and everything sterile that needs to be sterile. Hope you guys enjoyed the video. As always, thank you for sharing, commenting, liking the video.
All right. So I hope that just gave you probably a little bit more information than you thought. All right, I'll give you the questions at the end. So scrubbing and donning sterile attire. You guys are so familiar with this. This is going to be an easy part of the chapter. Read through that technique. The techs have already got you really well versed at this. With the scrub, self-drying, self-gowning, all of that. So just read through that and just refresh your memory on the actual technique. Closed gloving, of course, again, you're completely comfortable with this. I feel like you guys are very proficient at it. You're ready to even pass your, well, if I can get over to the book. There we go. I feel like you guys are completely prepared for this. And so the book, just allow the book information just to serve like as a refresher. So, all right. Prep the sterile field. Now, turning the closed gloving, of course, read through this technique, and the turning the gown technique, just read through that. Just making sure that you are fully aware of what he mentioned in the video with that pro tip with passing the card. You want to make sure that you're passing so that you as a scrub tech are touching one end of it, circulators touching the other end, and that they're circling around you so that you are holding the same piece, that once they get around and they hand you the tie, you're no longer touching that card and can discard that. So you want to make sure that you're familiar with how that works. And once you get in the into the lab, you're going to be practicing with that. We've got a lot of cards. I know that Deanna's getting more cards. You saw draping the Mayo stand. You guys know how to do that already. Make sure you're reading through that and getting re-familiar with that. And then, of course, like you mentioned, organizing those instruments and supplies. You're creating that working space on one end and expanding that back table by draping the Mayo stand. Okay. All right, organizing the instruments in the, so let's look at another video on organizing the back table, and then we're gonna watch one as well on organizing the Mayo stand. Of course, there's different ways that people are doing that, and it's been a few days since I watched this video, so I wanna make sure it's the right one.
As I go through
Hello everybody, Mike here from Surg Tech Academy, and today I'm going to demonstrate one way to organize a back table. Now, one of the many things I love about surgical technology is that there are many ways to organize back tables, and each hospital, and dare I say each Surg Tech, has the only way to do it. But in reality, I think there are two rules to remember that I teach my students. The first rule is that there isn't a right or wrong way to do anything. There's only sterile and non-sterile ways of doing things. And as long as it's sterile, it's safe, and I think it's okay. The second rule I tell my students is that you need to set up in a way that makes you comfortable. One of the biggest obstacles to overcome in surgery is anxiety. And whether you are nervous around a certain surgeon or whether it's a certain surgery that you haven't scrubbed, you want to be comfortable in the OR. One way to do that is to watch other surgical technologists. Watch them how they set up, and then you can meld those techniques to become your own. Now, if things get stressful in a case, you want to make sure that your setup is automatic and you know exactly where everything on your back table is. So, I've already opened my supplies, I've scrubbed my hands, gowned and gloved. For the demonstration and education purposes, I do not have a mask on, but I think everything else is ready to go. Now, I have pre-organized this pack to coincide with many I see around the state of Iowa. But I understand that there are all different ways and all different arrangements in slightly different manners. And like I said earlier, there aren't many ways to organize a back table, but there are a few practices that I think are pretty universal and overall really good ideas. Now, the one thing to make sure is to cover your back table with a second layer, and whether that be half sheets or towels, I think it's a good practice to place a second layer on there just to reinforce the plastic of the pack and to help prevent instrument trays from breaking through. Now, since I have a ton of towels, I'm going to reinforce this entire table with towels. Now, the second practice we need to consider is which side of the patient will we be standing on so that we can dictate on which side to put our basin and pitcher. I like my basin, pitcher, and needle count pad close to me since I will be constantly using those. So I'm going to put my drapes furthest away from me because we will place those on the patient right away and we'll no longer need that end of the back table. So if I'm on the patient's right, the drapes are on the right. Patient's left, drapes are on the left. Now for my students, I pretend that we are always on the patient's right. Hence, my basin, pitcher, kidney basin, and all needle count pad will be put on the left so they're closest to me. I also like putting my pitcher closest to the end of the back table so that the circulator can fill the saline up for me. Now, one thing to remember is that it's a good idea for motion economy to try and only move things once. Now, I am demonstrating this, so I am moving some things twice, but just know that our goal is to move it once. Now, next we have to put the drapes in the right place. Now, we need to remember to have the drapes prepared and in order. At this point, I only want to put them in order because once my back table is completely set up, I will then often pull the tape off the tape drapes, pre-fold the towel cuffs, just to be completely prepared for when the surgeon comes in and isn't ready. Towels go into the back right. Four towels for draping, medium sheet. I'm going to put these under here. Next, Mayo stand. So we do have some knife blades and we do have some suture. Oftentimes I'll actually drape the Mayo stand first. I did it a little later this time, but I'm going to go ahead and do that now. I am going to prepare another video strictly for draping and organizing a Mayo stand. All right, so our knife blades go up there. Our one suture can go up there. Even your suction and your bovie can go up there also, I think. Now, a third practice that I think is pretty universal is that I find that the instrument set is at the back of the table with the instrument tips pointing out, and the set is usually centered. Now remember to stay at least 12 inches away from the instrument container when you retrieve the set. So when you retrieve the set, make sure you're 12 inches away, only grab the inside of the container and set it in the middle of your back table with the tips pointing out. Now the last practice that I think is pretty universal is that I see a lot of surgical techs using an instrument roll. I don't personally ever do this because I like the uncluttered look of keeping my instruments in the tray. But I do like the idea of having the instruments a little more forward so you can just reach them when you move back and you're standing and you want to grab something. So there's a couple of ways to do the towels. So one way I see is just to keep the towel folded in half and to roll it this way. I personally don't like this method. I like rolling it lengthwise and folding it in half. Now the reason I like doing this is because when I fold it in half, I think it's a little bit fatter and I think a little bit longer than we would have it just with half a towel. Once we have the towel down, we can pull out our instruments, set them on the towel, and I think we are ready to go. So that, my friends, is organizing a back table.
Okay, so now we're going to look at organizing the Mayo stand.
Going to be scalpel, scissors, forceps, clamp. Today, I'm going to demonstrate how to dress a Mayo stand and one way to organize a Mayo stand. Now, there are many ways to organize back tables and Mayo stands, and each hospital, and dare I say each surge tech, has the only way to do it. But in reality, I think there are two rules to remember that I teach my students. The first rule is that there isn't a right and wrong way to do anything. There is only sterile and non-sterile ways of doing things. And as long as it's sterile, it will be safe, and I think it's okay. The second rule is that you need to set up in a way that makes you comfortable. One of the biggest obstacles is to overcome anxiety. Whether you are nervous around a certain surgeon or whether it's a surgery that you haven't remembered or scrubbed much, in any case, set up in a way that you are familiar with and do what makes you comfortable. Watch other surgical technologists to see how they set up and meld all those techniques and make something that makes sense to you. So first, my case is open, I've scrubbed my hands, I've gowned and gloved, and I probably have organized part of my back table or maybe all of my back table. Now, normally I'd have a mask on, but for educational purposes, my mask is off today. So now it's time to perform the first part of the demonstration and dress the Mayo stand with a sterile Mayo stand cover. First, I like to have my students firmly grasp the Mayo stand cover and situate their hands over the back table. Manufacturers have made it pretty error-proof by putting the words right hand and left hand directly on the Mayo stand cover. And I like to have the students situate their hands over the back table so that when it comes time to actually address the unsterile Mayo stand, they aren't preoccupied by moving their hands around and they might accidentally contaminate themselves. So I address the Mayo stand from the front and place the opening of the cover around the Mayo stand. I grab the Mayo stand top. At this point, you have good control of the stand and you're fairly free from contamination. Next, I place my foot on one of the Mayo stand footrests to prevent it from moving around. Then I tell my students to belly up. By bellying up to the Mayo stand, this prevents the Mayo stand from falling down below waist level, which will contaminate it. And then continue to feed the cover over the Mayo stand. Now, I know a lot of surgical techs stress the Mayo stand from the side, and that's fine, but for new people and students, I think this method is the best because it doesn't open up the possibility of presenting your back to the back table and accidentally contaminating it. And I'm going to go ahead and put 2 towels over it. Two key points at this time is I want to make sure to not let the cover or your hands drop before the Mayo stand or below waist level. The second point I want to make is to make sure that you stay on or behind the cuff of the Mayo stand, and that ensures you don't contaminate. So after the Mayo stand is completely covered, place at least 2 towels on it and make sure all the surfaces are covered. I've seen a lot of different ways to do this. Some people like to tuck the towels in between the tray and the stand, and really they're all good techniques, just as long as all the edges are covered. Okay, now that we have a sterile Mayo stand, let's begin to organize it. Now there are a lot of different ways to set up a Mayo stand. I tend to be pretty simple in mine. There are people who like rolled towels on their Mayo stand, and there are those that don't. Do you want the blade closest to you or furthest from you? You know, sharps container on the Mayo stand or not? All these are good questions, and all these techniques are good. And people have good explanations for why they do what they do. Now for me, I teach not to use a rolled towel on your Mayo stand. I think having a rolled towel, you can put a lot of instruments on there. But for me, I like to be able to grab an instrument without looking at it. So when I don't use a towel, I know where everything is on the Mayo stand. I like my knife blades furthest away from me. It's the sharpest instrument on the Mayo stand, and I like it further, the most further, to reduce the risk of cutting myself. Now, no matter if I use a towel or not, my setup is always going to be the same. It's going to be scalpel, scissors, forceps, clamps, and hemostats. For this hernia setup, I'm going to put up 2 number 3 knife handles, a curved Metzenbaum scissors, a straight Mayo scissors, a curved Mayo scissors, 2 DeBakey forceps, an Adson forceps with teeth, 2 Cokers, 2 Alices, and 6 Peon hemostats. I feel like I need to say a partridge in a pear tree after that. So you could use cryos in place of the Kellys or in place of the Peons. I think it's really surgeon's preference. So I'm going to go ahead and start putting that stuff up now. Also make sure to clamp your instruments on the first clamp so they don't open up when you hand them to the surgeon. On the back row, I always like to put my retractors, 2 Army Navies, 2 Sens, and for some reason, I put my 2 Babcocks back there also. My X-ray detectable sponges always go into the back left-hand corner, and I always preload my stitch. There you go. A simple and organized Mayo stand for a simple case like maybe a hernia repair. Now, there you have it, folks. How to properly.
Okay, so there is another take on the Mayo stand. So to me, the most important point that he made was finding the way that works the most efficient and comfortable for you so that it reduces your anxiety, instills confidence, and provides you that efficiency so that as you're anticipating what's going to happen in the case, you also know exactly where on your table it's at every single time so that you're placing your sharps in the same place on your table every time and that you have a method to it. So it's really about creating that method that you're repeating every time. Okay, now let's move on to creating and maintaining the sterile field. So here it's about you've got your sterile field created through setting up your back table, you're created sterile, and your back table and your mail stand are set up. So everything is created, and now it's about maintaining that. And part of that is the count. And so making sure that you're doing that pre-op count, but like it was said in one of these, the videos where there wasn't a count because there weren't opening the body, then that negates the need for a count. So, but you want to make sure that you definitely know how to do the count on sponges, sharps, and instruments. So looking at the book, here's your pre-op count, talking about that. So prior to opening, you're going to be counting instruments, sponges, sharps, and needles. When you would count in the OR, of course, the first count is done before there's any incision made. Once there is a cavity within a cavity created, then a count would be necessary when they're closing a cavity within a cavity. And so this would be like when they're doing a C-section. The C-section is opening the abdominal cavity is one cavity, then open the uterus up is another cavity. So when that inner cavity is being closed, then a count is necessary to make sure that nothing has been retained in that inner cavity. Also during a closure of a body cavity. So like during closure of the peritoneum, then you're going to count then as well. So then it's that outer cavity. And then the last count is that final count before the final sutures are placed to close the wound. Problems that may come up with the count, of course, instruments, changing the count sheet to match the actual count from that initial count is very important to make sure that those changes are corrected. Sponges, same thing. If you're going to count those twice. If there is a problem, you can open a new package and count again. If the incorrect sponge package stays in the OR, then the circulator can place those in a bag and set them aside until the end of the procedure, that if they're needed. And also, if they're needed, then that correct count would be reflected. The sharps and needles, those will be counted twice as well, document problem or count them again. So if there's any problem with any of these, you can see that you're going to be counting those again. Okay. All right, so now there's also some electronic methods for counting that are coming into the technology world. And so there's radio frequency identifications, especially that you'll see this on in the sponges, so that allows us to use that handheld wand and just pass it over the patient at key points and just make sure that there's no retained sponges that are left. And so it really just kind of helps clear that. So, but then also instruments are being identified so that you can use a scanner to identify that all the barcodes match. So that's a way to kind of just help along with the count process. All right, assisting a team member. So this is, it could be a second scrub that is already scrubbed in and has their sterile attire on. Also, it could be other team members that are scrubbing in as well. So they assist other team members who perform their scrub and they're ready to enter the sterile field. So let's look at that. This is, there's a lot of different types of cases. So there's a non-sterile person going to help, of course, with all of this. So you're having a circulator. That's the role that we're talking about, basically, assisting a team member in the drying, gowning, gloving. And so you guys should have all that practice in the lab of pretending to be the circulator and helping your surgeon and your scrub tech get prepared. Now, draping the surgical patient, there are 19 core principles that you want to make sure that you are familiar with, that you read through and you're familiar with all of those. And so here, starting with number one, following the procedures are typically accomplished prior to draping, da, 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 da. So I'm not going to read through all of this. Just make sure that you're reading through this and that you're familiar with the problem solving as well. That if there's contamination, what are you going to do? You're going to discard it? Are you going to replace it? Are you going to cover it up? Holes that are discovered, they can be covered immediately with an impermeable material, or else the place has to be completely removed and replaced. You know, we do have those adhesive towels, and so you can use one of those impermeable towels that have that adhesive edge to cover up any holes. So those are great to have in cases. That's why we have a lot of them in the lab. They're in the packs for that type of a purpose, and so they help correct any of those errors. Perforating towel clips, you know, so if those are unfastened after the initial placement, they should be removed from the sterile field, and it should be covered with either like a half or 3/4 drape or towel. So, okay, so, all right. So now I've got some videos on each type of draping here. So we're just going to watch those really quick. I want you to read through it on a book, but this is a great way just for you to get familiar with the different types of draping for each of these types of procedures.
I just wanted something better for myself.
I was starting to get comments from well-meaning people.
Draping of the abdomen. This video will demonstrate draping of the abdomen for surgical procedures such as a laparotomy, bowel resection. We have our scrub nurse here. She's going to be applying the first square drape. Notice how she's approaching the patient, ensuring that she's covering herself and protecting her hand as she's applying the square drape. She's going to take the second square drape and she's going to hand the second drape to our resident here, who will then approach the patient to apply the square drape. As she applies the drape, she's careful to protect her hands, preventing contamination of her glove. The last drape is a laparotomy drape. The scrub nurse removes all the adhesive tape, looks for the hole in the drape, and there's also a man drawn on the drape that tells the scrub nurse the orientation. You always want to make sure the head of the patient matches the head of the person on the drape. That's the orientation that you will be using. As she applies the drape, she applies a bit of pressure on the abdomen to ensure that the adhesive is applied correctly. She gives one end of the drape to the resident, and they drape the bottom of the patient's body, and then they unfold the top. The top of the drapes will be clipped onto the IV pole. Now they've established their sterile field. The scrub nurse then wheels over the Gerhardt table with the assistance of the circulating nurse. Here, the circulating nurse is adjusting the height of the table to ensure that the patient's foot is not directly pressed against the table.
Here, the scrub nurse is then unraveling all her cords. One cord is the suction, and the other cord is the electrosurgery unit cord, more specifically the monopolar cautery. Once the cords are secured in place, she will then use the extension of the Gerhardt table she places towel clips to secure the extension of the Gerhardt table cover. For the beginning of surgery, the first instruments that are given to the surgeon, it's usually some sponges, a blade, forceps, some snaps, ribbons, and a section is also there. She'll also use a marking pen as well with a ruler. Now they're ready for surgery.
Okay, so that was abdominal. I'll let it go a little bit longer than just the draping, but it's just good to see a lot of different approaches.
For surgical procedures such as a laparotomy, bowel resection, we have our scrub nurse here. She's going to be applying the first square drape. Notice how she's approaching.
Sorry, it didn't go through. I'll get it. Let's look at extremity.
Hello everybody, and welcome to Surge Tech Academy. I want to remind you that if you haven't already, please subscribe to my channel for the latest videos and notifications. Today we're going to be talking about draping a patient's extremity. In particular, I have chosen to use an arm as if we were performing a carpal tunnel or some other hand surgery. Draping is one of those skills that can be pretty scary for new people because each surgeon has their own method and ideas of what the right way to drape is. And incidentally, studies have shown that contamination most often happens during draping. So double gloving during draping and changing them before the procedure is a great practice. With extremity draping, there are many variations. Surgeons who use a stockinette, some don't. Some use an impervious stockinette, some use cloth. And again, some use a plastic U-drape, some don't. Some put towels around the tourniquets. You get the picture. There are all sorts of differences. So I'm going to demonstrate some of the basic concepts in draping a patient's extremity, knowing that there are many ways to do it. So the circulator has finished prepping the patient and is holding the arm in an elevated position. I have a couple helpers with me today. One of my cameramen, Kirk, is going to be the circulator, and my good friend Emma is my surgeon. Now our first step is to put a medium sheet over the hand table or the arm board. It's not important to have the surgeon help because I think it's a pretty cramped spacing. So I'm going to go ahead and put the medium sheet down, making sure I create a cuff and that I don't contaminate my hands. The next step is to give the surgeon the stockinette. They're going to grab the hand so that the circulator can get out of the picture. All right, got it. And we're going to completely unroll the stockinette to over the tourniquet, making sure that we stay on top and under the cuff of the tourniquet. I'll go and finish up. I like to try and get it completely over the tourniquet just to get that completely covered and out of the way. While the surgeon has a hold of the arm, I'm going to go ahead and grab the U-drape. Now, I didn't have a plastic U-drape in the lab, so I'm actually going to use a fenestrated U-drape, but just know that it would be one of the plastic ones. I'm going to go ahead and set it down. I'm going to get rid of the tape. And I'm going to place the U-drape in front of the tourniquet. Awesome. At this point, the surgeon could put the hand down. All right, then lastly, we have the extremity drape. Manufacturers have done a great job with all these fenestrated drapes. They tell us which way to go for the feet. Oftentimes they have a little person on them to show you where to place it on the patient. So I'm going to go ahead and put my hand in the hole. Go ahead and grab this, please. And pull the arm through the extremity hole all the way up to the tourniquet. I'm going to unfold. Go ahead and drop it. I'm going to create a cuff. Hold that for me. And I'm going to extend the drape down, covering the patient's legs. And I'm going to do the same for the patient's head. There you go. And that's it. Hooray! We have just correctly performed draping a patient.
Okay, let's look at the craniotomy and then I'll get the perineum for you.
This tiny tweak to your morning coffee melts stubborn fat all day long. If you drink coffee...
The Cardinal Health neurological drape is used for craniotomy cases. To begin, remove the release liner to expose the full adhesive film. Follow the markings to ensure the pouch is positioned toward the floor. Follow directional arrows and open to the sides. Remove the release liner to expose the adhesive strip. Follow the directional arrows and open the drape. The large pouch flips open for suction, and the tabs can be used for managing cables.
That's the gist of it. I'll email you guys the perineum one. Okay, timeout. So timeout is the phase of the case where this is the last opportunity to confirm that you've got the correct patient, the correct procedures being done. There's other items too. The video that I'm going to show you, it is a training video, so keep in mind it may be a little more in-depth than what an actual OR timeout is. If you guys have not been practicing that, you will be practicing that next term. And so this is going to be performed after the patient is positioned, prepped, and draped. And I see there's a typo there, but there's some important items that are included in that timeout. So you want to make sure you refer to the book so that you're familiar with that. But
is everybody ready for a timeout?
Yes.
Yes. Yes. Okay. Carrie Rosencrantz, surgery.
Cam Clark, anesthesia.
Kelly Carey, scrub nurse.
Pat Stockwell, circulator. The patient is Betsy Smith. She was identified on the way in, correct?
Correct.
Yes. We are planning to do a left mastectomy and sentinel lymph node biopsy. She has a green circle marking the left side. She is appropriately positioned supine. Site, as I mentioned, is marked. She requires no blood products.
Correct.
Cam, allergies.
She has a severe penicillin allergy, and because of that, we've chosen vancomycin as her antibiotic, and that started at 9:30.
Thank you. She is wearing Venadines, Pat?
Yeah, and they are turned on.
Thank you. Images are left-sided and they have been confirmed. Pathology, we will have 2 specimens at least. The mastectomy will go directly to pathology. We may have frozen sections on the sentinel lymph nodes. Okay. Special equipment, implants, and irrigation fluid. The gamma probe is in the room, correct?
Yes.
And it has been checked?
Yep.
Kelly, medications on the field.
I have xylocaine 1% with epi 1 to 200,000, 30 mLs, expires 3/13, and I have normal saline as well.
Thank you. Cam, any anesthesia or airway concerns?
She's otherwise healthy, had a normal airway, She is at a high risk for post-op nausea and vomiting, and if there's no contraindication to dexamethasone, I would be giving her full prophylaxis.
Dexamethasone is fine with me. Thank you.
Thank you.
She is full code. Does everybody agree?
Yes.
Yes.
Any special issues or safety concerns?
Not otherwise.
Just a reminder, Pat, the nodes should go labeled radioactive to pathology.
Okay.
Yep. Any other safety concerns? No. Is
No.
everybody okay?
All set?
Yes.
Okay. Thank you.
Thank you.
Let's go.
So of course, those are some techniques that, or some topics that are covered in an ideal situation, but the items that should include, of course, patient identity, the procedure to be performed, the operative side and site, surgical markings, and nowadays they're doing the surgeon's initials, the correct position, supplies and equipment available, including any implants and then other components. So, okay, hope that helped. And then of course the marking, the incision site, there's going to be a sterile skin marker along with a ruler that are going to be available. The surgeon's going to use those for marking the incision line, as well as I mentioned their initials. Okay. Intraoperative case management. So these are things that are going to be going on during that. So this is the time during your job that one of your main concerns, of course, is maintaining the sterile field and just that growing that anticipation. So you're constantly comparing anatomy and pathology of what you're seeing in the case compared to what should be expected. So it helps you identify abnormalities, and that is going to help with that anticipation. So just being aware of keeping up on anatomy and making sure that you're always studying that before your cases. Now, safety, there's standard precautions for safety, of course. This is with your sharps, with your electrical surgical pencils, making sure that they're in the holster at all times. Using that neutral zone. Double gloving is, of course, a great technique, as well as all other PPE. And then appropriate protection from the environmental hazard. So, we've talked in previous chapters about fire hazards, water hazards, electrical. So just about making sure that you're maintaining a very safe environment. Now, verbal communication is going to be key as everyone is communicating to make sure that the process is moving forward smoothly. There's also nonverbal communication. So at this point, you're going to be making sure you're learning those hand signals. You can look in let's get to their nonverbal. So we have those hand signals that A, that's the hand signal for requesting a hemostat. B, this is for requesting tissue forceps. C, for scissors. D, for a suture. So you want to make sure that you know those four at minimum. And of course, there's a lot more that you could get familiar with. And then making sure that you know how to pass those instruments to a patient, to a physician. So, passing a surgeon to the surgeon's right hand, you're going to use your right hand. And the same with if you're passing it to their left hand, you're using their your left hand. I do have a couple of good training videos, so I want to make sure that you're seeing this in the setting. So,
welcome to Basic Instrument Passing. You have before you CST extraordinaire standing at the Mayo stand and the surgeon across from her. Typically, when you are passing instruments from the Mayo, you will have both a surgeon and an assistant surgeon. One will be across from you and one will be standing next to you, either on the right or left side. What you see in front of you is a basic Mayo setup for a basic case. And so now we will begin with basic instrument passing.
Knife. And I am not watching. Thank you. And notice how when I grabbed that, I had this kind of tucked away hidden to keep myself safe and my surgical team safe. If they were to reach back, I want to make sure they're not going to stab themselves. So I'm going to pull it out just like I'm going to hand it to them. The blade, the sharp end, is pointed down or facing down. I am leaving enough room for them to grab, but I'm also protecting myself and them from the blade. And I place it in their hand like a pencil.
I'm taking it like a pencil, and that is how it is used. So you have to think about how each instrument is being used. And then
That's the
take it
blade.
back.
Sometimes they'll hand it back to you like that. I'm gonna put it back where I had it.
And pick up.
See how I grabbed them by the tips? Putting them in their hand like a pencil. Exactly how they're gonna use it. My hand is not in her way, and then I'm up and away.
And I can use it. Bovie.
Again, passing it like a pencil. You can either pass it from behind like that. That's usually how I place it, or if I'm over here, but I'm not holding on to the active electrode.
And I'm gonna be pushing the buttons. So when you pass it, it's helpful if you pass where the buttons are on top so that their finger or their thumb can be used to press each button. And hemostat.
And when I pass a ringed instrument that is curved, I'm passing it where once they have it in their hand and it goes in the patient, the curve is going to be down. So see how I'm putting it in her palm like that? And the curves are now facing down. If she were left-handed, I could pass to her left hand just like that. So see, now that curve is going down in like that.
And I would use it with left hand.
So all you would have to do is just a simple flip. If she has her right hand out, then I'm putting it like that. If I see that she wants the hemostat in her left, all I'm doing right here, holding on to the box lock, I'm just flipping it, just like she's gonna use it. I don't have to switch hands to then rotate it. That takes too much time. So I'm going from, oh, nope, she doesn't want it with her right hand, flipping it, left hand.
Okay, retractor.
And I'm looking at the incision and I see that we're a little bit deeper. If we were superficial, I may pass, you know, this Senreg or an Army Navy, which has two different ends, but we're getting a little deeper, so I'm going to pass the more shallow end of the Richardson. So I'm just handing that to them exactly how they're gonna use it. She's just gonna take it just like that.
Just like that.
Okay?
Hemoclip.
So then I have my hemoclip. It would be loaded. I would have checked for scissoring prior to loading it. That's all you have to do before you load it, is just do this right here. Make sure the tips line up and they don't scissor. Then I would load it. It's loaded and I'm passing it. This one you want to be a little more delicate, because if you slap it into their hand, that clip will fall out and they will not be able to use it. So I'm being a little more delicate, placing it in their hand, getting a second one ready, because usually they take at least two at a time.
And put no pressure on the instrument. You're only holding the box lock with very little pressure, because even the slightest squeeze, the clip will just fall out and then it's empty and you can't use it. Let's do meds.
Okay. And so see how I locate, ooh, those are not the meds. Sorry, doctor. See how I located? I use my other hand. So don't just think you can only use one hand, okay? So I have these on a little roll towel or a foam one, and so I'm using this hand. I can move those out of the way and I'm reaching straight for the correct instrument this time, and I'm passing the scissors with the curve once it goes into the patient facing down. Again, if she were left-handed or wanted them in the left hand, I just have to flip it just like that.
Let's do Gelpy.
Okay. Gelpy, you have to be very careful passing a Gelpy to your surgeon. You have to be careful for yourself and for them. So there's two different ways you can pass it. I like to pass it like this on top. So when I pass to them, they take it. I am up and away. You never pass it and drag down, because it will cut you. So I'm passing it and doing it away. Or another way you can pass it is holding it like this, like just on the side, on this side where I can get away from it. So I'm passing it to them and I'm just letting go.
And I am not watching your hand, so as soon as I feel the instrument in mine, I'm going into the incision. Let's do Babcock. Peon.
And so notice how I didn't have time to put this up. So she was ready for the next one. I just dropped it, gave her that she needed while she's working on that. Now I can put this up where it goes. They don't have time to wait for you to be like, where did I put this last time? Well, they're waiting on that next instrument. So I just set it down. I'll tend to that later, pass the next instrument, and now I can place this while I have a little bit of time. And once you get a little more seasoned, you'll be able to anticipate. So I'll say, oh, on this case, every time after she's done with the pee on, she wants a sponge stick. So I'm already gonna have that in my hand. So as soon as I hand that back, I'm going to take with one, pass with the other. And now I can put this up into Bakey. See how I passed that to her left hand? I noticed which hand that she wanted. I just picked it up, held it by the tips, and put it in her hand like she's gonna use it.
Now notice that the surgeon is standing directly next to the CST. And now the CST will pass accordingly.
Bovie. Okay, so now she is on my right side. So you have to think about, are they on my right, my left, across from me? How am I passing? What hand am I passing to? So you saw how I was normally passing with just my right hand to her right. So now she's next to me. I don't want to bump arms like this. I am right hand dominant, so I had to learn to use my left hand as well. And so now I'm going to pass, I'm going across, passing that, and then as she is bovieing, I have the suction. I'm not going to pull on the cord. I have the suction, so I am suctioning the bovie plume, the smoke, to keep it out of their vision. I'm not touching the tip of that, and I'm not getting in their line of view, but I'm suctioning the smoke.
You can follow the retractor that the surgeon's using, and you should be out of the view of the surgeon. Okay?
If the assistant is not already doing this, you would be doing this.
And
okay?
if the assistant is not grabbing it, it's okay if you pick up the suction to use it. You don't have to ask. Okay. Hemoclip.
So now I'm going to pass this with this arm. So now look at all this room I have. I'm not doing this and bumping this arm that is holding a retractor or a sharp or whatever else they are holding on to with this arm. I'm not going to do this right here. I'm coming around and I'm creating that space and passing it just there. I'm getting another hemoclip ready. Then I'm taking that. And then if she wanted another one, I'd pass her the other loaded one.
Hemostat. One thing surgeons might do is they will not look at your Mayo to hand instruments back to you. They will simply toss it. Peon.
And so just like I did earlier, she tossed it. I will fix that later. I went for exactly what she asked for next, passed it. Now I can put this up where it goes if I have time. So that way I always know and I have it set up exactly like it was. Because your hands, once you get used to your setup, your hands will find it before your eyes do. So you'll know, oh, this is where I always keep my hemostat. This is where I always keep my peon. Did you ask for a hemostat or a peon?
Peon.
Okay, good. I just noticed my hemostat was there. And so always knowing what you're passing your surgeon. So you don't ever want to pass the incorrect instrument. She asked for a peon. If I had passed the coker that has teeth or Ochsner, it would crush what she was meaning to clamp. So always know what you are passing your surgeon, and you just have to look at the tips and pass it to them. So you don't pass ones that look similar.
Should we do a blade on this side?
Yeah.
Blade.
Okay, so now I'm grabbing my blade with my left hand. There would be no way for me to safely pass this with my right hand with her on my right. So I grabbed it with my left, passing it across. I'm making sure they have it, and I'm up and away.
Yeah, let's do DeBakey.
So DeBakey, so I'm grabbing with my left, placing it like a pencil, just like that. If she were to need something with her left hand, same thing. So
right angle.
Okay, so right angle. So I'm going to grab this and do it like that. So the point is facing down, and I created that space. Instead of doing this, which would be easy, so it's there, I'm grabbing it. If I have it like this, that's wrong. All I have to do is flip, same hand, there you go.
Let's do hemostat and DeBakey pickups.
So I'm going to put that there, and then sometimes you may have to do this right here, but that's only if you're passing two at the same time, just like that. But generally, if you're passing one at a time, you want to make sure you're creating that space.
Sen.
So a sen rake, so it has a sharp end and a dull end, so you can kind of look, but sometimes if you don't know, I'm gonna pass it with the sharp end so that way they see it, and I'm giving that to her just like that. If she needed to flip it, I would know next time, give her the dull end. And always watch, anytime you pass an instrument, moments after you pass it, if the surgeon needs to flip an instrument or adjust it, they will, usually without saying anything. So they'll flip it and then hand it back without a word, and then they'll ask for a send rake again, and then if you don't flip it to fix what they had to, then they will say something. So always watch the moment after you pass anything.
Okay, now those two videos I think are going to be very helpful as you guys learn how to correctly pass instruments, and as your techs start to practice with you in the lab. So you may want to watch those several times, keep those as some of your favorites to help you get really efficient at passing instruments. So here's what we just we're seeing, you know, the way to pass the scalpel, the ringed instruments, retractors, lap sponge, and those specialized ones. Okay, so important things you want to consider as you're working to maintain that order in sterile in your sterile field. You're going to have everything arranged so that each one is picked up and passed easily in one smooth movement. And then each time you're using that bovie, once it's returned, you want to check it really quick for cleanliness, and that's one way you can use some sponges on your table just to keep that cleaned. And then clean sponges are going to be added as they're needed. Most instruments, once they're done with, sometimes they're going to put them on the drapes when they're no longer needed in the case. Also, open procedures kind of follow the same sequence of events. So I want you to be very familiar with what that sequence is. We're going to look at, there's a table in the book. I think it's progression. Yeah. Okay, so make sure that you're very familiar with this table where you know that an incision is made and what you need to do at that point. So you're passing, you know, to make that incision, you got to pass a scalpel. You're going to also want to make sure that they've got some sponges. Prep, you know, having that bovie and suction ready. Hemostasis is going to be achieved with that bovie. So anticipating if they're going to need hemostats there, if that bovie's not effective. Clean sponges added to the field. Dissection is going to continue through the necessary layers. So you want to have things ready if they need sharp dissection or scissors, blunt dissection if they're going to need that. Oh, if they're going to be using a dissecting sponge or their fingers, bovie, things of that nature. Also making sure that as soon as it's ready for this wound to be retracted, that you've got the retraction equipment ready. And then as they move through the procedure, that you're making sure that the instruments and suture materials are ready for that. And then of course, wound irrigation is going to be continuous through the case as needed. Wound is closed, dressing applied. So just make sure that you read through all of that and are comfortable with that. Also, there's always going to be the potential for additional supplies to be on the field. Your circulator is going to be able to provide that. And many times circulators are as familiar with the cases as you are, so they may be anticipating that. Intraoperative and closing counts, of course, these are very common as far as what you're going to count. Sharps, sponges, instruments. When there is an incorrect sponge count or incorrect any count, you know, you're going to look at what are you going to do to correct that. You know, so in the book, there's some techniques that explain what you're going to do in the event of an account. I think that was in the book. I read that. Let me see. Stop the show a second. Okay, I'm not really sure where I had read that, where it was talking about exactly what to do in those counts in the event that they are incorrect. And just remember that a lot of it is about making sure that you're communicating with your circulator, because the initial count, of course, is the most important, because you're kind of setting that baseline of what is going to be expected to be counted at the end. And so that's one of the most important things, is making sure that you have that initial count correct, so that as you are counting in the during the case and at the end of the case, that any incorrect count is brought to the attention, so that if the case is not ended, then that can be looked for and that can be corrected. Okay, let's see. Okay, medication handling. So this is very important. We saw it in one of the videos. We talked about it in chapter 9. So you want to make sure that you're reviewing that, and how that medication errors are very dangerous in the OR setting. So you want to make sure that you're vigilant about this and keeping that to a minimum. So make sure that you're always familiar with those anesthetic agents, medications and solutions that are going to be used during any kind of surgical case. Specimen care, we're going to talk about this in the next chapter, so next term, about specimen care. The techs are going to work with you in the lab, making sure that you're very comfortable with how to handle that those specimen. And it's really as simple as just making sure that you have the container labeled correctly, whether it is a frozen section, you know, from a breast biopsy, or if it is something that's going, you know, directly to pathology. So you're just wanting to make sure that everything is labeled as far as the site it was removed from, what it is, all of those parameters that are needed. And then, like I said, we'll talk about it next term in more detail in 13. You can feel free to go ahead and read through chapter 13 just to be getting yourself familiar with this. So now we're going to talk about if things are contaminated in the OR setting. So I've got 3 videos for you to watch on contaminated gloves, as well as 2 different videos on gloves. But then there's a third one on if your gown is contaminated, how you're going to manage that.
Since I started Noom, I've lost 70 pounds.
I've lost 97 pounds with Noom.
I've lost 92 pounds.
Good job.
We're now going to demo what you would do if you contaminate yourself while the circulating nurse is the only one in the room with you. She's removed your glove container, and you inadvertently touched the unsterile Mayo stand.
I'm so sorry.
This is what you will do in that instance. You do not have to re-scrub for this, because you're going to be able to take your gown off, and your gloves will be taken off in a method to prevent you from having to totally re-scrub. The circulating nurse undoes the gown. You'll face the circulating nurse. She'll remove the gown. And now what she's going to do is remove your gloves, not touching your skin. She will pull them off. And it's just like you've come in from the scrub sink.
And that's basically it on that one. You're going to start back where you were when you first walked in the room. You're going to do a very simple technique if you contaminate just the gloves alone.
Sometimes you need to take a glove off during surgery because maybe you ripped a glove or you punctured a glove with a needle. And the best way to do that is to actually have a non-sterile assistant help you out with that, because then you can maintain a closed gloving situation. So what you need to do is you need to hold your hands out to the person that's going to take the gloves off. They're going to grab your sleeve and the glove on both sides of your hand, and then they're going to pull and you're going to pull, and then you can keep your hand nice and sterile still in your sleeve. And so then I could just go and re-glove this hand. Sometimes you need to do both hands. You always tell your assistant to not pinch you when you do this. Ow! Because it hurts. Pull it off, and then I can re-glove both if I need to.
Okay, this is basically the same thing, just a little bit different perspective.
Hey guys, this is competency number 21, changing a contaminated glove during a case. This is what we do if we contaminate our top glove. Another reason why we always double glove. But all you're going to do is grasp the base of the cuff of the glove, peel away, and discard it off the field. At this point, you can grab a new set of gloves, and you can open glove the hand to then be double gloved again.
Okay. Super easy there. All right. On the wound dressings, we got to get back over to the book for this because there is just too many to list. There's, of course, dressing applications. It's going to be dependent on the case, of course. We've talked about different types of wound healing, whether it be first intention, second intention, third intention. And so the wound dressing is going to depend on that first and foremost. Once the case is finished, the area around the wound is going to be cleaned and dried, and that's going to be very important, but you don't want to disrupt those wound edges. So moist and dry sponges are prepared. So the dressings are arranged in order that they're going to be applied. And so that's really important that you're seeing how that technique is followed. Now, the techs are going to work with you as well on different types of dressings for different types of techniques. And so that is going to be very dependent on your surgeon and their preference card. So just keep that in mind, that there's no way to know exactly what kind of dressing is going to be applied with every single type of case, because that's not going to be the case. Okay. Now, preserving the sterile field, of course, this is really important, and making sure that things are maintained as the case is closing. So as you can see, removing the drape, removing the gowns and gloves of the surgeon and then of yourself as well. And so making sure that everything remains sterile while the surgical team members that are beside the case are removing the drape. So you're really making sure that you're continuing to keep your sterile field protected until the patient is out of the room. And so this is one thing that's really important that you're aware of. And now, immediate post-op patient care, of course, the patient's going to be transferred out of the room. Once the patient leaves the room, then at that point, it is okay to break that sterile field, not until then. And then, of course, the patient's going to be transported to the PACU for their recovery. And then once they're out of the OR, then you can begin to break down the setup. And so, of course, there's going to be routines that you can practice that. So removing your gown and glove, removing the drape, because this is going to be done so that all of the biohazards are maintained on the inside. So the gown and glove is going to be, as you saw that scrub nurse removing it and folding it basically, and then it goes into the waste receptacle. Drapes are the same. You're going to remove those, making sure that as much biohazard material is remaining inside. Oh, I was thinking that there was a picture, but there's not. The book doesn't have very many pictures. So, okay. So in this chapter, hopefully you've learned what the role is for you in caring for the patient, pre-op routines, principles of surgical positions, case management, prepping for surgery, handling the equipment, post-op routines, so forth and so on. Okay, some things that I want to make sure that you answer is I want you to give me what that pro tip was in that movie with, I think his name is Shane, the surge tech tips guy. There was a pro tip that the circulator gave. I want you to make sure you tell me what that was. And then in a cardiovascular case, what was it that he said you have to make sure that you have? And several of them mentioned how many times is optimal for you to move one item. Okay. Okay. All right. Do you place the instrument tray on the back table prior to the filter being checked in the box that you removed it from? I want you to think about that and answer that. So there was those 4 questions. Tell me what the pro tip was. In the cardiovascular case, what do you need to make sure that you have in a cardiovascular case? How many movements do you want to move each thing? And do you place that tray on the table prior to checking the filter? So you just stand there and hold it, because what if you put it on the table and that filter came back not intact? Then you have just placed a contaminated instrument tray on your back table, and so you have to start all over. So just keep that in mind. All right, I will get this posted and get it out to you guys.